Hello and welcome to Chronic Pain Tips for Patients. I'm Dr. Yuri Martins, and in this episode, we are going to talk about one of the most common reasons people seek medical care: low back pain. Low back pain is extremely common. In fact, it's one of the leading causes of disability worldwide. Hundreds of millions of people live with low back pain, and most adults will experience it at some point in their lives. For some people, it's a short episode. They burn the wrong way, lift something heavy, wake up with pain, or have a flare after activity. A few days or weeks later, they feel much better. For others, low back pain becomes recurrent and persistent. It may come and go over months or years. It may interfere with work, sleep, exercise, walking, sitting, standing, and quality of life. When low back pain lasts longer than 3 months, we usually call it chronic low back pain. The first thing I want patients to understand is this: most low back pain is not dangerous. But that does not mean it's not real. Low back pain can be very real, very frustrating, and very disabling, even when an MRI does not show one single dramatic finding. A common misunderstanding is that every case of back pain must come from one specific structure: a disc, a joint, a nerve, a muscle. Sometimes that's true, but very often low back pain is caused by several factors working together. The lower back includes muscles, ligaments, discs, small joints, sacroiliac joints, bones, and nerves. Pain can come from one of these structures, but it can also come from a combination of irritation, inflammation, muscle guarding, reduced movement, poor sleep, stress, and increased sensitivity of the nervous system. This is why some patients are told they have non-specific low back pain. That phrase can sound dismissive, but it should not be. It does not mean the pain is imaginary. It means that no single disease or structure fully explains the pain. And this is important because the best treatment is often not one pill, one injection, or one surgery. The best treatment is usually a thoughtful plan. Let's talk about some of the common patterns of low back pain. The first pattern is back dominant pain, sometimes called axial low back pain. This is pain mainly in the lower back. It may spread into the buttock, hip, or upper thigh, but the back is the main location. This type of pain may come from muscles, ligaments, discs, facet joints, sacroiliac joints, or a combination of several contributors. The second pattern is sciatica, also called radicular pain. This pain generally travels from the back or buttock into the leg, often below the knee. It may feel sharp, burning, electric, or shooting. Some patients also have numbness, tingling, or weakness. This pattern often suggests irritation of a nerve root, sometimes from a disc herniation or narrowing around the nerves. Another common condition is lumbar spinal stenosis. This is more common as people get older. Spinal stenosis means that there is narrowing around the nerves in the lower back. The patient may feel pain, heaviness, numbness, or weakness in the legs when walking or standing. Symptoms often improve when sitting or bending forward. One important characteristic of this type of pain is that patients notice they can walk further when leaning on a shopping cart. It's called the shopping cart sign. Another possible source of pain is the facet joints. These are small joints in the back, part of the spine. They can become painful from arthritis or degeneration. Facet joint pain is usually felt mostly in the back. It may spread to the buttock, hip, flank, or upper thigh, but the majority of pain will be felt in the back. The sacroiliac joint can also cause low back and buttock pain. This joint connects the spine to the pelvis. Pain from this area may be worse with sitting, standing up from a chair, climbing stairs, or rolling in bed. Now, because low back pain is so common, it's very important to know when it may be a sign of something more serious. Most low back pain is not an emergency, but some symptoms should prompt urgent medical evaluation. These warning signs include new loss of bladder or bowel control, inability to urinate, numbness in the groin or saddle area, progressive weakness in one or both legs, severe pain after major trauma, fever, chills, recent serious infections, history of cancer with new back pain, unexplained weight loss, or severe pain that keeps worsening and does not improve with rest or position changes. One emergency that patients should know about is caudal equina syndrome. This happens when the nerves at the bottom of the spinal canal are severely compressed. Symptoms may include bladder or bowel problems, numbness in the saddle area, severe back pain, symptoms on both legs, or progressive weakness. This condition requires urgent evaluation and usually urgent MRI. Now let's talk about imaging. Many patients with low back pain wonder whether they need an MRI. MRI can be very helpful in the right situation. It is important when we suspect infection, cancer, fracture, caudal equina syndrome, severe nerve compression, or when surgery or procedure is being considered. But routine MRI is not recommended for every episode of low back pain. One reason is that many MRI findings are common even in people without pain. Changes like disc bulges, arthritis, degeneration, and wear and tear are more common as we age. These findings may matter in some patients, but they do not automatically explain the pain. A good MRI interpretation always depends on the patient's story, physical exam, and pain pattern. The MRI should support the clinical evaluation. It should not replace it. Now, let's talk about prognosis, or how the disease generally evolves. The outlook for low back pain depends on the cause. Most acute non-specific low back pain improves substantially within several weeks. However, recurrence is common. Some patients recover and then have another flare later, but some patients continue to have symptoms beyond 3 months. That means low back pain is often better understood as a condition that can fluctuate over time, rather than a single, isolated injury that always disappears forever. For disc herniation and sciatica, the natural course is often favorable. Many patients improve without surgery. In some people, the body can even partially shrink or reabsorb the herniated disc material over time. But I'm in the chronic pain field, so when I say over time, it means months or years, not weeks. Surgery may provide faster relief of leg pain in selected patients, but many patients who do not have surgery may also improve over time. For lumbar spinal stenosis, the course is often variable, but not always rapidly progressive. Some patients improve, many remain stable, and a smaller group worsens. Most patients do not suddenly become paralyzed from typical degenerative spinal stenosis. So, patients that have these symptoms most likely should not get worried. Treatment decisions should focus on pain, walking distance, daily function, independence, and quality of life. Compression fractures are different. These are fractures in the bones of the spine, often related to osteoporosis. Pain may improve over months, but the fracture may be a warning sign that bone health needs attention. Treatment should address pain, but also osteoporosis, fall prevention, and reducing the risk of future fractures. Inflammatory back pain is another important category. Conditions such as axial spondyloarthritis can begin in younger adults and may cause morning stiffness, pain that improves with exercise, and symptoms that do not improve much with rest. Early diagnosis matters because modern treatments can help many patients and may reduce long-term disability. Infection and cancer-related back pain are much less common, but they are serious. When they occur, early diagnosis and treatment are very important. Now, let's move to treatment. One of the most important treatments for low back pain is also one of the simplest ones. Stay active when it's safe to do so. For most patients, Prolonged bed rest is not helpful. Gentle movement and gradual return to activity are usually better than complete rest. This does not mean forcing through severe pain. It means avoiding unnecessary inactivity. When patients stop moving for too long, they can develop stiffness, weakness, fear of movement, and worsening disability. A helpful idea is that hurt does not always mean harm. Some discomfort during recovery is common, especially when return to movement after a flare. Exercise is one of the best supported treatments for chronic low back pain. There's no single perfect exercise for everyone. Walking, physical therapy, core strengthening, mobility work, Pilates-based exercise, Mackenzie-type exercises, aerobic conditioning, yoga, or Tai Chi may help different patients. The best exercise plan is the one that is safe, realistic, and sustainable. Exercise helps more than muscles. It can improve confidence, reduce fear, improve sleep, improve function, and help calm down an oversensitive pain system. Physical therapy can also be very helpful, especially when it's active and goal-oriented. A good therapy program should not only focus on temporary relief, it should help the patient understand the pain, move more confidently, and gradually return to daily activities. Sleep, stress, and mood also matter. Chronic pain and poor sleep reinforce each other. Pain makes sleep harder, and poor sleep makes pain feel worse. Stress, anxiety, depression, and fear of movement can also increase pain sensitivity and disability. This does not mean the pain is just psychological. It means the nervous system is part of the pain experience. Medications may help some patients, especially during flares, but they are rarely the complete answer. Anti-inflammatory medications, such as ibuprofen or naproxen, may help in the short term, but they are not safe for everyone. They can affect the stomach, kidneys, heart, blood pressure, and bleeding risk. Acetaminophen alone has not shown strong benefit for acute low back pain. However, it can be used as an adjunct together with other pain medications. Muscle relaxants may help selected patients for short periods, but they can cause sedation, dizziness, and falls. Opioids are generally not recommended for chronic low back pain. They carry risks such as dependence, constipation, sedation, overdose, hormonal effects, and sometimes worsening pain. Gabapentin and pregabalin are often used for nerve-related pain, but they are not routinely recommended for sciatica or non-specific low back pain because benefits are uncertain and side effects can be significant. Injections can help selected patients, but they are not for every type of low back pain. Epidural steroid injections may help selected patients with acute, severe sciatica caused by nerve root inflammation. The benefit is usually modest and short-term, but for the right patient, it may reduce pain enough to help them move, sleep, and participate in rehabilitation. For suspected facet joint pain, diagnostic medial branch blocks may be used to test whether the facet joints are likely pain generators. If the blocks provide strong temporary relief, radiofrequency ablation may be considered. Radiofrequency ablation uses heat to interrupt pain signals from small nerves that supply the facet joint. It does not cure arthritis and the nerves may grow back over time, but it can provide months of relief in well-selected patients. Sacroiliac joint injections may be considered when the pain pattern and physical exam suggest that the sacroiliac joint is a major contributor. Surgery is needed only for selected patients. Most low back pain does not require surgery. Surgery is most helpful when there is a clear structural problem that matches the symptoms and has not improved with appropriate non-surgical care. One example is persistent sciatica from a lumbar disc herniation. In selected patients, surgery may reduce leg pain faster than non-surgical treatment. However, after enough time has passed, Many patients who do not have surgery may also improve, so the long-term results can become similar. Surgery may be urgent in situations such as Cauda-Equina syndrome, spinal infection with nerve compromise, unstable fracture, or certain tumors. The key message is that low back pain care should not be random. It should not be an endless cycle of medications, imaging, injections, and referrals without a clear plan. A thoughtful approach starts by identifying the pain pattern. Is the pain mainly in the back? Is it traveling down the leg? Are there warning signs? Is the patient losing strength? Is walking limited? Is sleep poor? Is fear of movement preventing recovery? Then the plan should be matched to the patient. For many people, the foundation is education, movement, exercise, physical therapy, sleep improvement, stress management, and careful use of medication. Procedures or surgery may be helpful when the diagnosis and symptoms support them. So, the most important message today is this. Low back pain is common, real, and sometimes disabling. In most cases, it's not dangerous. Many patients improve with time, movement, exercise, education, and a plan that treats the whole pain experience. The goal is not simply to chase MRI findings. The goal is to understand the pain pattern, rule out serious problems, restore movement, reduce pain sensitivity, improve function, and use targeted treatments when they are appropriate. Thanks for listening to Chronic Pain Tips for Patients. If this episode was helpful, please follow the podcast, leave a comment, and share it with someone who may be struggling with low back pain. You can also learn more about chronic pain conditions and treatment options on my website, www.ycmartins.com. Again, that is www.ycmartins.com. I'm Dr. Yuri Martins, and I will see you in the next episode.